Welcome to this video about gastrointestinal drugs. In this video, we will discuss some of the common drugs used to treat a wide variety of gastrointestinal disorders ranging from stomach ulcers to diarrhea. So we are the reporters. I am Dorothy Joy B. Danielas.
And I am AC Crisea P. Reyes. And this presentation discusses gastrointestinal drugs and includes: first, classification actions of gastrointestinal system drugs. Second, examples of when, how, and to whom gastrointestinal system drugs may be administered. Third, identify the side effects and special considerations associated with gastrointestinal system drug therapy.
Fourth, identify considerations and implications of using gastrointestinal system medications across the lifespan. And fifth, we discuss an assortment of gastrointestinal drugs with indications ranging from emesis to colitis to hemorrhoids. Four groups are emphasized: antiemetics, antidiarrheal, drugs for irritable bowel syndrome, and drugs for inflammatory bowel disease. For our topic overview, general overview, gastrointestinal pharmacology deals with the properties and action of drugs affecting gastrointestinal system function. These drugs normalize impaired function in the GI tract. For definition, the drugs for the gastrointestinal system are designed for care and treatment of the digestive system organs, including the liver, biliary tract, and pancreas, and diseases that may affect those organs.
Drugs that affect the gastrointestinal: acid-related diseases, peptic ulcer disease, constipation, diarrhea, emesis, and digestion.
Peptic ulcer disease, or known as PUD, refers to a group of upper gastrointestinal disorders characterized by varying degrees of erosion of the gut wall. Severe ulcers can be complicated by hemorrhage and perforation. Although peptic ulcers can develop in any region exposed to acid and pepsin, ulceration is most common in the lesser curvature of the stomach and the duodenum. PUD is a common disorder that affects about 10% of Americans at some time in their lives. About 6 million Americans get ulcer each year. Before the mid-1990s, PUD was considered a chronic, relapsing disorder of unknown cause and with no known cure. Therapy promoted healing but did not prevent ulcer recurrence. We know that the most cases of PUD are caused by infection with Helicobacter pylori, and that the eradication of this bacterium not only promotes healing but greatly reduces the chance of recurrence.
Pathogenesis of peptic ulcers. Peptic ulcers develop when there is an imbalance between mucosal defensive factors and aggressive factors. The major defensive factors are mucus and bicarbonate. The major aggressive factors are H. pylori, nonsteroidal, anti-inflammatory drugs, gastric acid, and pepsin.
The relationship of mucosal defenses and aggressive factors to health and peptic ulcer disease. Defensive factors serve the physiologic role of protecting the stomach and duodenum from self-digestion. When defenses are intact, ulcers are unlikely. Conversely, when defenses are compromised, aggressive factors are able to cause injury. Two important agents that can weaken defenses are H. pylori and NSAIDs. Aggressive factors such as non-steroidal anti-inflammatory drugs, H. pylori infection, alcohol, bile salts, acid, and pepsin can alter the mucosal defense by allowing the back diffusion of hydrogen ions and subsequent epithelial cell injury.
Defensive factors. First is the mucus. It is secreted continuously by cells of the gastrointestinal mucosa, forming a barrier that protects underlying cells from attack by acid and pepsin. Second is the bicarbonate. It is secreted by epithelial cells of the stomach and duodenum.
Third is the blood flow. Sufficient blood flow to cells of the gastrointestinal mucosa is essential for maintaining mucosal integrity. And lastly is the prostaglandins. It plays an important role in maintaining defenses, and they provide additional protection by suppressing secretion of gastric acid. Aggressive factors. First is the Helicobacter pylori. It is a gram-negative bacillus that can colonize the stomach and duodenum by taking up residence in the space between epithelial cells and the mucous barrier that protects these cells. The bacterium manages to escape destruction by acid and pepsin. Next is the nonsteroidal anti-inflammatory drugs. These are the underlying cause of many gastric ulcers and some duodenal ulcers. Gastric acid is an absolute requirement for peptic ulcers generation. In the absence of acid, no ulcer will form. Acid causes ulcers directly by injuring cells of the gastrointestinal mucosa and indirectly by activating pepsin. It is a proteolytic enzyme. The example of gastric acid is the Zollinger-Ellison syndrome. It is the primary disorder in which hypersecretion of acid alone causes ulcers. The syndrome is caused by a tumor that secretes gastrin. It is a hormone that stimulates gastric acid production. For the aggressive factors, pepsin is a proteolytic enzyme present in gastric juice. Like gastric acid, pepsin can injure unprotected cells of the gastric and duodenal mucosa. Smoking delays ulcer healing and increases the risk of recurrence. For the topic overview, drug therapy. The goal of drug therapy is to alleviate symptoms, promote healing, prevent complications like hemorrhage, perforation, obstruction, and prevent recurrence with the exception of antibiotics. The drugs employed do not alter the disease process. Rather, they simply create conditions conducive to healing. Since non-antibiotic therapies do not cure ulcers, the relapse rate following their discontinuation is high. In contrast, the relapse rate following antibiotic therapy is low. For the classes of anti-ulcer drugs, first is the antibiotics, second is the anti-secretory agents, third is the mucosal protectants, fourth is the anti-secretory agents that enhance mucosal defenses, and lastly, the antacids.
The American College of Gastroenterology recommends that all patients with gastric or duodenal ulcers and documented H. pylori infection be treated with antibiotics. Helicobacter pylori associated ulcers. This recommendation applies to patients with newly diagnosed PUD or known as peptic ulcer disease, recurrent PUD, and PUD in which the use of NSAID is a contributing factor to hasten healing and relieve symptoms. An anti-secretory agent should be given along with the antibiotics. By eliminating H. pylori, antibiotics can cure PUD and can thereby prevent recurrence.
For drug selection, NSAID induced ulcer, prophylaxis for patients with risk factors for ulcer development like age over 60, history of ulcers, high-dose NSAID therapy, prophylactic therapy is indicated. Proton pump inhibitors like omeprazole are preferred. For the treatment, NSAID-induced ulcers can be treated with any ulcer medication. However, histamine 2 receptor blockers and proton pump inhibitors are preferred. And if possible, the offending NSAID should be discontinued so as to accelerate healing. If the NSAID cannot be discontinued, a proton pump inhibitor is the best choice to promote healing.
Effects of drugs on pepsin. The activity of pepsin is pH-dependent drugs that elevate gastric pH. For example, antacids, histamine 2 antagonists, proton pump inhibitors can cause peptic activity to increase, thereby enhancing pepsin's destructive effects. For example, treatment that produces a 99 reduction in gastric acidity will cause pH to rise from a base level of 1.3 up to 3.3. At pH 3.3, peptic activity will be significantly increased. To avoid activation of pepsin, drugs that reduce acidity should be administered in doses sufficient to raise gastric pH above 5. Pepsin is a proteolytic enzyme that can contribute to ulcer formation. So the enzyme promotes ulcers by breaking down protein in the gut wall. Like most enzymes, pepsin is sensitive to pH. As pH rises from 1.3, the usual pH of the stomach, to 2. Peptic activity increases by a factor of 4. As pH goes even higher, peptic activity begins to decline. Non-drug therapy. First, diet. Despite commonly held beliefs, diet plays a minor role in ulcer management. The traditional ulcer diet, consisting of bland foods together with milk or cream, does not accelerate healing. Furthermore, there is no convincing evidence that caffeine-containing beverages like coffee, tea, or colas promote ulcer formation or interfere with recovery. A change in eating pattern may be beneficial. Consumption of 5 or 6 small meals a day rather than 3 larger ones can reduce fluctuations in intragastric pH and may thereby facilitate recovery.
Antibiotics employed. First is declarithomycin. It suppresses growth of H. pylori by inhibiting protein synthesis. The most common side effects are nausea, diarrhea, and distortion of taste. Second is the amoxicillin. It kills bacteria by disrupting the cell wall. Antibacterial activity is highest in neutral pH and hence can be enhanced by reducing gastric acidity with an anti-secretory agent like omeprazole. The most common side effect is diarrhea. Third is the bismuth. It can impart a harmless black coloration to the tongue and stool. Patients should be forewarned. Stool discoloration may confound the interpretation of gastric bleeding. And fourth is the tetracycline. It is an inhibitor of bacterial protein synthesis. It is highly active against H. pylori. Resistance is rare, less than 1%, because tetracycline can stain developing teeth. It should not be used by pregnant women or young children. Tetracycline is an inhibitor of bacterial protein synthesis and it is highly active against H. pylori. Resistance is rare and less than 1 minute. For the antibiotics employed, metronidazole is very effective against sensitive strains of H. pylori. The most common side effects are nausea and headache. It is a disulfiram-like reaction that can occur in metronidazole. It is used with alcohol, and hence alcohol must be avoided. Next is the tinidazole. It is very similar to metronidazole and shares the drug's adverse effect and interactions. Like metronidazole, it should not be taken during pregnancy. Like metronidazole, tinidazole can cause a disulfiram-like reaction and hence must not be combined with alcohol.
Histamine 2 receptor antagonists. The H2RA are effective drugs for treating gastric and duodenal ulcers. These agents promote ulcer healing by suppressing secretion of gastric acid. 4 H2RA are available. First, cimetidine, second, ranitidine, third, famotidine, and fourth, nizatidine. All 4 are equally effective. Serious side effects are uncommon. Cimetidine tegomet works by blocking H2 receptors, which reduces the volume of gastric juices that are secreted. Cimetidine is best used for the treatment of gastric and duodenal ulcers, but can also aid in relieving symptoms associated with gastroesophageal reflux disease, Zollinger-Ellison syndrome, and heartburn. Mechanism of action. Histamine acts through two types of receptors named H1 and H2. Activation of H1 receptors produces symptoms of allergy. Activation of H2 receptors, which are located on peripheral cells of the stomach, promotes secretion of gastric acids. By blocking H2 receptors, cimetidine reduces both the volume of gastric juice and its hydrogen ion concentration. Cimetidine suppresses basal acid secretion and secretion stimulated by gastrin and acetylcholine. Because cimetidine produces selective blockade of H2 receptors, the drug cannot suppress symptoms of allergy. Pharmacokinetics. Cimetidine is available orally in solution or tablet. Food decreases the rate of absorption but not the extent. Hence, if cimetidine is taken with meals, absorption will be slowed and beneficial effects prolonged. Cimetidine crosses the blood-brain barrier and central nervous system. Side effects can occur. Although some hepatic metabolism takes place, most of each dose is eliminated intact in the urine. The half-life is relatively short, about 2 hours, but increases in patients with renal impairment. Accordingly, dosage should be reduced in these patients. The therapeutic uses. First, gastric and duodenal ulcers. Cimetidine promotes the healing of gastric and duodenal ulcers. To heal duodenal ulcers, 4 to 6 weeks of therapy are generally required. To heal gastric ulcers, 8 to 12 weeks may be needed. Long-term therapy with low doses may be given as prophylaxis against recurrence of gastric and duodenal ulcers. Second, the gastroesophageal reflux disease, or known as GERD. Reflux esophagitis is an inflammatory condition caused by reflux of gastric contents back into the esophagus. Cimetidine is a drug of choice for relieving symptoms. However, cimetidine does little to hasten healing. Third, Solinger-Ellison syndrome. This syndrome is characterized by hypersecretion of gastric acid and development of peptic ulcer. The underlying cause is secretion of gastrin from gastrin-producing tumor. Cimetidine can promote the healing of ulcers in patients with Solinger-Ellison syndrome, but only if high doses are employed. At these doses, significant adverse effects can occur. Fourth, heartburn, acid indigestion, and sore stomach. Cimetidine is available over the counter to treat these common acid-related symptoms. Adverse effects. This is the incidence of side effects is low and that do occur are usually benign. First, the anti-androgenic effects. Cimetidine binds to androgen receptors, producing receptor blockade. As a result, the drug can cause gynecomastia, reduce libido, and impotence, all of which reverse when dosing stops. Second, the CNS effects. Effects of the CNS are most likely in older adults who have renal or hepatic impairment. Possible reactions include confusions, hallucinations, CNS depression, for example, lethargy, somnolence, and CNS excitation, for example, restlessness or seizure. Third, pneumonia. Elevation of gastric pH with an anti-secretory agent increases the risk of pneumonia because when gastric acidity is reduced, bacterial colonization of the stomach increases, resulting in a secondary increase in colonization of the respiratory tract. Among people using an H2RA, the relative risk of acquiring pneumonia is doubled. However, the absolute risk is still low, about 1 extra case for every 500 people using the drug. Other adverse effects. By reducing gastric acidity, cimetidine may permit growth of candida in the stomach. Hematologic effects, for example, neutropenia, leukopenia, and thrombocytopenia. It occurs rarely. Minor side effects include headache, dizziness, myalgia, nausea, diarrhea, constipation, rash, and pruritus. For drug interactions related to inhibition of drug metabolism. Cimetidine inhibits hepatic drug metabolizing enzymes and hence can cause levels of many other drugs to rise. Drugs of particular concern are warfarin, phenytoin, theophylline, and lidocaine, all of which have a narrow margin of safety. If these drugs are used with cimetidine, their dosages should be reduced. Antacids. Antacids can decrease absorption of cimetidine. Accordingly, cimetidine and antacids should be administered at least 1 hour apart.
For ranitidine, it shares many of the properties of cimetidine. However, although similar to cimetidine, the drug differs in three important respects. First is the ranitidine is more potent, produces fewer adverse effects, and causes fewer drug interactions. Like cimetidine, ranitidine suppresses secretion of gastric acid by blocking H2 receptors on gastric parietal cells. It does not block H1 receptors and hence does not reduce symptoms of allergy. Ranitidine can be administered through PO, IM, or IV. Oral bioavailability is about 50%. In contrast to cimetidine, ranitidine is absorbed at the same rate in the presence or absence of food. Ranitidine's ability to enter the CNS is even less than that of cimetidine. Elimination is by hepatic metabolism and renal excretion. Accumulation will occur in patients with renal impairment unless the dosage is reduced. The half-life is 2 to 3 hours. For the adverse effect, significant side effects are uncommon because ranitidine penetrates the blood-brain barrier poorly. CNS effects are rare. In contrast to cimetidine, ranitidine does not bind to androgen receptors and hence does not cause anti-androgenic effects like gynecomastia, impotence. Elevation of gastric pH may increase the risk of pneumonia. For the drug interactions, ranitidine has few drug interactions. In contrast to cimetidine, ranitidine is a weak inhibitor of hepatic drug metabolizing enzymes and therefore does not greatly depress metabolism of other drugs. Antacids have a small effect on ranitidine absorption. For therapeutic uses, short-term treatment of gastric and duodenal ulcers, prophylaxis of recurrent duodenal ulcers, treatment of Zollinger-Ellison syndrome and other hypersecretory states. Next is the treatment of GERD, because it produces fewer side effects than cimetidine and because of its greater potency. Ranitidine is preferred to cimetidine for treating hypersecretory state. For preparation, dosage, and administration. For preparations, ranitidine Zantac is available in standard tablets like 75, 150, and 300 mg capsules. 150 and 300 mg, and for syrup, it is 15 ml or 15 mg for oral use, and in solution, 25 mg or 25 ml for parenteral use. For the oral dosage, the usual adult dosage for treatment of gastric or duodenal ulcer is 150 mg twice a day. Alternatively, a 30 mg dose can be given once daily at bedtime. For patients with Zollinger-Ellison syndrome, higher dosage may be required. The dosage for preventing recurrence of duodenal ulcer is 150 mg once daily at bedtime. Ranitidine can be administered without regards to meal. Next is the parenteral dosage. The usual parenteral dosage, IM or IV, is 50 mg every 6 to 8 hours. Intramuscular dosage can be injected without dilution. For IV injection, the preparation should be diluted to a volume of 20 ml in 0.9 sodium chloride injection and administered slowly over 5 or more minutes. For IV infusion, the drug should be diluted in 100 ml or 0.9% sodium chloride injection and administered over 15 to 20 minutes.
Famotidine Pepsid. It is much like ranitidine. The drug is approved for the treatment and prevention of duodenal ulcers and the treatment of gastric ulcers, GERD, and hypersecretory states. For example, Solinger-Ellison syndrome. An over-the-counter formulation is approved for heartburn, acid indigestion, and sore stomach. Like ranitidine, famotidine does not bind to androgen receptors and hence does not have anti-androgenic effects. Elevation of gastric pH may increase the risk of pneumonia. Famotidine does not inhibit hepatic drug metabolizing enzymes and hence does not suppress the metabolism of other drugs. Preparations, dosage, and administration prescription. Strength famotidine Pepsid is available in standard tablets 10, 20, and 40 mg. Orally disintegrating tablets 20 and 40 mg. Powder for oral suspension 40 mg over 5 ml when reconstituted. And solution 0.4 and 10 mg over ml for IV use. For treatment of duodenal and gastric ulcers, the dosage is 20 mg twice daily or 40 mg once daily at bedtime. To prevent recurrence of duodenal ulcers, the dosage is 20 mg once daily at bedtime. For treatment of GERD, the dosage is 20 to 40 mg twice daily. For treatment of hypersecretory states, the initial dosage is 20 mg every 6 hours. Severe cases may require up to 160 mg every 6 hours. All doses should be reduced in patients with moderate to severe renal impairment, in patients taking ibuprofen for treatment of osteoarthritis and rheumatoid arthritis. Famotidine is available in combination with ibuprofen in a tablet containing 800 mg of ibuprofen and 26.6 mg of famotidine sold as Duosix. For over-the-counter, famotidine is available in 20 mg standard tablets and chewables marketed as Pepsid AC Maximum Strength and in 110 mg formulation of standard tablets marketed as Pepsid AC. Indications are prevention and relief of heartburn, acid indigestion, and sore stomach. To prevent symptoms, the drug is taken 1 hour before eating. The dosage for prevention or relief is 10 mg taken with a glass of water. As with prescription strength famotidine, dosages should be reduced in patients with moderate to severe renal impairments.
Nizatidine is much like ranitidine and famotidine. The drug is used to treat and prevent duodenal ulcers and to treat gastric ulcers, GERD, heartburn, acid indigestion, and sore stomach. For preparations, dosage, and administration, nizatidine is much like ranitidine and famotidine. The drug is used to treat and prevent duodenal ulcers and to treat gastric ulcers, GERD, heartburn, acid indigestion, and sore stomach. For prescription, strength nizatidine is available in capsules 150 and 300 mg and in oral solution is 15 mg or 15 ml. The dosage for treatment of active gastric and duodenal ulcer is 150 mg twice daily or 300 mg once daily at bedtime. To prevent recurrence of duodenal ulcers, the dosage is 150 mg once a day at bedtime. For the treatment of GERD, the dosage is 150 mg twice daily. For the over-the-counter, it is available in 75 mg capsules. The dosage for preventing heartburn is 75 mg, taken anytime in the 30-minute interval preceding meal.
Famotidine and nizatidine both work similarly to the other H2 blockers and aid in the treatment of indigestion and sore stomachs. Even more effective than H2 blockers in the treatment of peptic ulcer disease, GERD, Solinger-Ellison syndrome are proton pump inhibitors, or known as PPIs, which can completely inhibit acid secretion as well as have a long duration of action. PPI have the higher ulcer healing rates, faster control of peptic ulcer disease symptoms, and are more effective in preventing NSAID-induced gastroduodenal toxicity. PPI are used for short-term therapies and are generally well tolerated. However, long-term use has been associated with several safety concerns, such as increased risk of fractures, pneumonia, and intestinal infections. To ensure that the benefits of treatment outweigh the risk, treatment should be limited to appropriate candidates who have to take the lowest dose needed for the shortest time possible. Omeprazole Prilosec. It was the first PPI available and will serve as our prototype for the group. Acid suppression is greater than with the H2RAs. Side effects for short-term therapy are minimal. Omeprazole Prilosec is one of the older PPIs on the market and is used for short-term treatment of ulcers and reflux. Mechanism of action. Omeprazole is a prodrug that undergoes conversion to its active form within parietal cells of the stomach. The active form then causes irreversible inhibition of H+, K+, minus ATPase proton pump, the enzyme that generates gastric acid. Because it blocks the final common pathway of gastric acid production, omeprazole can inhibit basal and stimulated acid release. A single 30 mg oral dose reduces acid production by 97% within 2 hours. Because inhibition of the ATPase is not reversible, effects persist until new enzyme is synthesized. Partial recovery occurs 3 to 5 days after stopping treatment. Full recovery may take weeks. Pharmacokinetics. After oral dosing, about 50% of the drug reaches systemic circulation. Omeprazole undergoes hepatic metabolism followed by renal excretion. The plasma half-life is short, about 1 hour. However, because omeprazole acts by irreversible enzyme inhibition, effects persist long after the drug has left the body. Omeprazole is acid-labile and hence must be protected from stomach acid. To accomplish this, the drug is formulated in a capsule that contains protective enteric-coated granules. The capsule dissolves in the stomach, but the granules remain intact until they reach the relatively alkaline environment of the duodenum. For the adverse effects, first, minor effects. Effects seen with short-term therapy are generally inconsequential. Like the H2RAs, omeprazole can cause headache, diarrhea, nausea, and vomiting. The incidence of these effects is less than 1%. Second, pneumonia. Omeprazole and other PPIs increase the risk of community-acquired and hospital-acquired pneumonia. Possible causes include alteration of upper gastrointestinal flora owing to reduced gastric acidity and impairment of white blood cell function. Of note, the time frame for increased risk is limited to the first few days of PPI use. After that, risk is no higher than non-users. Third, long-term therapy, especially in high doses, increases the risk of osteoporosis and fractures by reducing acid secretion, which may decrease absorption of calcium. However, the risk appears to be low. For example, only one extra hip fracture would be expected for each 1,200 patients. To minimize fracture risk, treatment should use the lowest dose needed for the shortest duration possible. Also, patients should be encouraged to maintain adequate intake of calcium and vitamin D. Drug interactions. By elevating gastric pH, omeprazole and other PPIs can significantly reduce absorption of atazanavir, delaverdine, and nilfinavir, all used to treat HIV/AIDS. These drugs should not be combined with a PPI. Reducing it can also decrease the absorption of two antifungal drugs, ketoconazole and itraconazole.
Lansoprazole. It is very similar to omeprazole. Both drugs can cause prolonged inhibition of H+, K+, and negative ATPase. Hence, suppression of acid secretion is sustained. Like omeprazole, lansoprazole is well tolerated. The most common adverse effects are diarrhea, abdominal pain, and nausea. Elevation of gastric pH may increase the risk of pneumonia. Prolonged high-dose therapy may pose a risk of hypomagnesemia as well as osteoporosis and fracture. Two oral formulations are available. First is delayed-release capsules, 15 and 30 milligrams. Next is the oral disintegrating delayed-release tablets, 50 and 30 milligrams. Both formulations should be taken immediately before a meal. The dosage of duodenal ulcers, prevention and treatment, and GERD is 15 milligrams once daily. The dosage of erosive gastritis and active gastric ulcers is 30 milligrams once daily, and for hypersecretory states, the initial dosage is 60 milligrams per day. For severe cases, up to 90 milligrams twice daily may be needed. For dexlansoprazole, it is simply the R enantiomer of lansoprazole. Although both enantiomers are active, the R enantiomer has a longer duration. Like lansoprazole and all other PPIs, dexlansoprazole reduces gastric acidity by inhibiting gastric H+, K+, negative ATPase. To prolong effects, dexlansoprazole is formulated in dual delayed-release capsules that contains two types of pH-sensitive granules. Following ingestions, some of these granules release lansoprazole when they reach the proximal small intestine, and the remainder release lansoprazole when they reach the distal small intestine. As a result, drug levels first peak 1 to 2 hours after dosing and then peak again 4 to 5 after dosing. In clinical trials, the most common adverse effects were diarrhea, abdominal pain, nausea, vomiting, flatulence, and upper respiratory infection. Long-term therapy may pose a risk of hypomagnesemia, as well as osteoporosis and fractures. Dexlansoprazole is approved for treatment and maintenance of erosive esophagitis and for treatment of symptomatic GERD or heartburn. Two strengths are available, 30 milligrams and 60 milligrams. The dosage of treating erosive esophagitis is 60 milligrams once daily for up 8 weeks.
Rabeprazole as effects period. Is much like omeprazole and lansoprazole in actions, uses, and adverse effects. The drug is approved for H. pylori eradication, duodenal ulcers, GERD, and hypersecretory states such as Zollinger-Ellison syndrome. Like other PPIs, rabeprazole suppresses acid secretion by inhibiting H+, K+, minus ATPase in parietal cells. However, in contrast to omeprazole, the drug causes reversible inhibition of H+, K+, minus ATPase, and hence its effects are less durable. In addition to suppressing acid secretion, rabeprazole has antibacterial activity.
For pantoprazole, it is similar to omeprazole and the other PPIs. The drug is approved for treating GERD and hypersecretory states. Like other PPIs, pantoprazole is well tolerated. Like lansoprazole, pantoprazole may be administered through PO or IV. With oral therapy, the most common adverse effects are diarrhea, headache, and dizziness. With IV therapy, the most common adverse effects are diarrhea, headache, nausea, dyspepsia, and injection site reactions, including thrombophlebitis and abscess. With both routes, Elevation of gastric pH may increase the risk of pneumonia. Long-term therapy may pose a risk of hypomagnesemia as well as osteoporosis and fractures. Pantoprazole does not affect cytochrome 450 enzymes and hence does not affect the metabolism of other drugs. Pantoprazole is available in three formulations. First is delayed-release tablets, 20 and 40 milligrams. Next is the enteric-coated granules, 40 milligrams, that can be sprinkled on applesauce or mixed with 5 ml of apple juice for oral administration or mixed with 10 ml of apple juice for administration by nasogastric tube. And lastly, the powder.
Other anti-ulcer drugs. Sucralfate carafate is an effective anti-ulcer medication notable for minimal side effects and lack of significant drug interactions. The drug promotes ulcer healing by creating a protective barrier against acid and pepsin. Sucralfate has no acid neutralizing capacity and does not have decreased acid secretion. Mechanism of anti-ulcer action. Sucralfate is a complex substance composed of sulfated sucrose and aluminum hydroxide. Under mildly acidic conditions, sucralfate undergoes polymerization and cross-linking reactions. The resultant product is a viscid and very sticky gel that adheres to the ulcer crater, creating a barrier to back diffusion of hydrogen ions, pepsin, and bile salts. Attachment to the ulcer appears to last up to 6 hours. Pharmacokinetics. Sucralfate is administered orally and systemic absorption is minimal to 3% to 5%. About 90% of each dose is eliminated in the feces. Therapeutic uses. Sucralfate is approved for acute therapy and maintenance therapy of duodenal ulcers. Rates of healing are comparable to those achieved with cimetidine. Controlled trials indicate that sucralfate can also promote the healing of gastric ulcers. Adverse effects. Sucralfate has no known serious adverse effects. The most significant side effect is constipation, which occurs in 2% of patients because sucralfate is not absorbed. Systemic effects are absent. Drug interactions. Interactions with other drugs may be minimal. By raising gastric pH above 4, antacids may interfere with sucralfate's effects. These interactions can be minimized by administering these drugs at least 3 minutes apart.
Next is the misoprostol. It is a synthetic prostaglandin medication used to prevent and treat stomach and duodenal ulcers, induce labor, cause an abortion, and treat postpartum bleeding due to poor contraction of the uterus. It is taken by mouth when used to prevent gastric ulcers in people taking NSAIDs. In addition to its use in PUD, misoprostol is used to promote cervical ripening and in combination with mifepristone to induce medical termination of pregnancy. In mechanism of action, in normal individuals, prostaglandins help protect the stomach by suppressing secretion of gastric acid, promoting secretion of bicarbonate and cytoprotective mucus, and maintaining submucosal blood flow. By promoting vasodilation, aspirin and other NSAIDs cause gastric ulcers in part by inhibiting prostaglandin biosynthesis. Misoprostol prevents NSAID-induced ulcer by serving as a replacement for endogenous prostaglandins. For therapeutic use, isoprostol is an analog of prostaglandin E1. In the United States, the drug's only approved GI indication is prevention of gastric ulcers caused by long-term therapy with NSAIDs. In other countries, misoprostol is also used to treat peptic ulcers unrelated to NSAIDs. For adverse effects, the most common reactions are those related diarrhea 13 to 40% and abdominal pain of 7 to 20%. Some women experience spotting and dysmenorrhea. For laxatives, it is used to ease or stimulate defecation. These agents can soften the stool, increase stool volume, hasten fecal passage through the intestine, and facilitate evacuation from the rectum. When properly employed, laxatives are valuable medications. However, these agents are also subject to abuse. Misuse of laxatives is largely the result of misconceptions about what constitutes normal bowel function. For dietary fiber, proper function of the bowel is highly dependent on dietary fiber, the component of vegetable matter that escapes digestion in the stomach and small intestine. Fiber facilitates colonic function in two ways. First, fiber absorbs water, thereby softening the feces and increasing their mass. Second, fiber can be digested by colonic bacteria, whose subsequent growth increases fecal mass. The best source of fiber is bran. Fiber can also be obtained from fruits and vegetables. Ingestions of 20 to 60 g of fiber.
Laxatives can be highly beneficial when employed for valid indications. By softening the stool, laxatives can reduce the painful elimination that can be associated with episiotomy and with hemorrhoids and other anorectal lesions. In patients with cardiovascular diseases like aneurysm, myocardial infarction, softening the stool decreases the amount of strain needed to defecate, avoiding dangerous elevation of blood pressure. In older adults patient, laxatives can help compensate for loss of tone in abdominal and perineal muscles. As an adjunct to anthelmintic therapy, laxatives can be used for first obtaining a fresh stool sample for diagnosis, second emptying the bowel before treatment so as to increase parasitic exposure to anthelmintic medication. Third, facilitating export of dead parasites following anthelmintic use. Fourth, emptying of the bowel before surgery and diagnostic procedures. Fifth, modifying the effluent from an ileostomy or colostomy. 6. Preventing fecal impaction in bedridden patients. 7. Removing ingested poisons. 8. Correcting constipation associated with pregnancy and certain drugs, especially opioid analgesics. Precautions and contraindications to laxative use. Laxatives are contraindicated for individuals with certain disorders of the bowel. Specifically, laxatives must be avoided by individuals experiencing abdominal pain, nausea, cramps, or other symptoms of appendicitis, regional enteritis, diverticulitis, and ulcerative colitis. Laxatives are also contraindicated for patients with acute surgical abdomen. In addition, laxatives should not be used in patients with fecal impaction or obstruction of the bowel, because increased peristalsis should cause bowel perforation. Lastly, laxatives should not be employed habitually to manage constipation. Reasons for this are discussed under laxative abuse. Laxatives can be highly beneficial when employed for valid indications. By softening the stool, laxatives can reduce the painful elimination that can be associated with episiotomy and with hemorrhoids and other anorectal lesions. In patients with cardiovascular diseases like aneurysm, myocardial infarction, softening the stool decreases the amount of strain needed to defecate, avoiding dangerous elevation of blood pressure. In older adults patient, laxatives can help compensate for loss of tone in abdominal and perineal muscles. As an adjunct to anthelmintic therapy, laxatives can be used for first obtaining a fresh stool sample for diagnosis, second emptying the bowel before treatment so as to increase parasitic exposure to anthelmintic medication. Third, facilitating export of dead parasites following anthelmintic use. Fourth, emptying of the bowel before surgery and diagnostic procedures. Fifth, modifying the effluent from an ileostomy or colostomy. 6. Preventing fecal impaction in bedridden patients. 7. Removing ingested poisons. 8. Correcting constipation associated with pregnancy and certain drugs, especially opioid analgesics.
Senna is a plant-derived laxative that contains anthraquinones as active ingredients. The actions and applications of senna are similar to those of bisacodyl. Anthraquinones act on the colon to produce a soft or semi-fluid stool in 6 to 12 hours. Systematic absorption followed by renal secretion may impart a harmless yellowish-brown or pink color to the urine. Castor oil is the only stimulant laxative that acts on the small intestine. As a result, the drug acts quickly in 2 to 6 hours to produce a watery stool. Hence, unlike other stimulant laxatives, which are all group 2 agents, castor oil belongs to group 1. The use of castor oil is limited to situations in which rapid and thorough evacuation of the bowel is desired. The drug is too powerful for routine treatment of constipation because of its relatively prompt action. Castor oil should not be administered at bedtime. The drug has an unpleasant taste that can be improved by chilling and mixing with the fruit juice.
For the treatment, the first step in breaking the laxative habit is abrupt cessation of laxative use. Following drug withdrawal, bowel movements will be absent for several days. The patient should be informed of this fact. Any misconceptions that the patient has regarding bowel function should be corrected. The patient should be taught that one's daily bowel movement may not be normal for him or her, and that stool quality is more important than frequency or quantity. Instruction on bowel draining, heeding the defecatory reflex, establishing a consistent time for bowel movements should be provided. Increased consumption of fiber like bran, fruits or vegetables, and fluid should be stressed. The patient should be encouraged to exercise daily, especially after meals. Finally, the patient should be advised that if a laxative must be used, it should be used briefly and in the smallest effective dose. Agents that produce catharsis must be avoided.
Other gastrointestinal drugs. A drug used for its effect of the gastrointestinal system, like controlling gastric acidity, regulating gastrointestinal motility and water flow, and improving digestion.
Antiemetic drugs. The various classes of antiemetics target different proemetic pathways to alleviate nausea and vomiting. Some target more than one pathway. The classes of antiemetics include antagonists of dopamine, serotonin, neurokinin, histamine, and acetylcholine. Ondansetron sufran was the first serotonin receptor antagonist approved for XIV. The drug is also used to prevent nausea and vomiting associated with radiotherapy and anesthesia. In addition, the drug is used off-label to treat nausea and vomiting from other causes, including childhood viral gastritis and morning sickness of pregnancy. In all cases, benefits derived from blocking type 3 serotonin receptors located the CPZ and an afferent vagal neurons in the upper gastrointestinal tract. The drug is very effective by itself and even more effective when combined with dexamethasone. Administration may be oral or parenteral. The most common side effects are headache, diarrhea, and dizziness. Glucocorticoids. Two glucocorticoids, methylprednisolone, solomedrol, and dexamethasone, are commonly used to suppress CINV, even though they are not approved by the U.S. Food and Drug Administration or known as FDA for this application. Glucocorticoids are effective alone and in combination with other antiemetics. The mechanism by which glucocorticoids suppress emesis is unknown. Both dexamethasone and methylprednisolone are administered IV because antiemetic use is intermittent, and short-term, serious side effects are absent.
The scopolamine is our most effective drug for prevention and treatment for motion sickness. Benefits derived from suppressing nerve traffic in the neuronal pathway that connects the vestibular apparatus from the inner ear to the vomiting center. The most common side effects are dry mouth, blurred vision, and drowsiness. Most severe but less common effects are urinary retention, constipation, and disorientation. Scopolamine is available for oral, subcutaneous, and transdermal dosing. The transdermal system is an adhesive patch that contains scopolamine and is applied behind the ear. Anticholinergic side effects with transdermal administration may be less intense than with the oral subcutaneous dosing. For antihistamine, the antihistamine used most often for motion sickness and are dimenhydrinate, medicine, and cyclizine. Because these drugs block receptors for acetylcholine in addition to receptors for antihistamine, they appear in a subclass under anticholinergic. So, suppression ng motion. Side effects are dry mouth, blurred vision, urinary retention, and constipation results from blocking muscarinic receptors. Antihistamines are less effective than scopolamine for treating motion sickness, and sedation further limits their utility.
For our summary, a drug used for its effects on the gastrointestinal system, example controlling gastric acidity, regulating gastrointestinal motility and water flow, and improving digestion. The principal functions of the gastrointestinal tract are to digest and absorb ingested nutrients, and to excrete waste products of digestion. Most nutrients are ingested in a form that is either too complex for absorption or insoluble, and therefore indigestible or incapable of being digested. These products are responsible for inhibition of acid production due to histamine, castrin, and acetylcholine. Also, pepsin secretion is reduced. Nocturnal and basal acid secretion is affected mostly, which helps in peptic ulcer healing by these drugs.